Hello, everyone. It's Steve Edelman again. I'm sure you met me several times during the day, so I'm not going to waste any time introducing myself. But I do want to remind you that I have type 1 diabetes myself for 50 years, 50. And I do have some kidney issues, and I thought it'd be nice to invite my kidney doctor, my nephrologist, Bethany Carl, and we're going to talk about everything you want to know about diabetic kidney disease. Bethany, please introduce yourself and give us a little background.
Yes, thank you, Steve, for having me. And I am so excited to be speaking with all of you virtually today. My name's Bethany Carl. I am a nephrologist here at UC San Diego Health. And as Dr. Edelman said, I am his nephrologist. I really love taking care of diabetic kidney disease, which we'll talk a little bit more about. But I really enjoy empowering patients and educating patients and making sure that they understand what I think about when I look at their labs and when I look at their vital signs and everything too, so they can actually take care of themselves away from the clinic, because ultimately whatever you do is it's much more important than anything that I could recommend or do for you. So, this is your life, and these are all, lifestyle changes that we're recommending for you, but only you can actually take that next step to make the difference for yourself. So again, thanks for having me, and let's get on with the questions.
All right, Bethany. So please don't call me Dr. Edelman anymore, but I appreciate the respect. No one else gives it to me. Okay, so I think we're going to start off just with what is diabetic kidney disease and what causes it, and when does it typically start?
Sure. So if you really just break down the word diabetic kidney disease, so we have something, some type of insult to the kidney that is seen in diabetic patients. And there actually has been lots of research done specifically with type 1 diabetics when we did not have good treatments for this in the past, to really understand the natural history of what we're seeing in regards to diabetic kidney disease. And so what we do see is that with the high sugars, the hyperglycemia, the inflammation, which activates a lot of other hormones and growth factors, we see that the kidney is stressed, and we see that there is a filter of the kidney called the glomerulus. And it's this filter that takes the brunt of the burden of this disease. And so that filter, that glomerulus, tends to get first a bit overactive and may actually start to hyperfilter. And with that, the pressure increases in that filter, which causes increased pressure in the kidney and can cause leakage of protein, or what you may also know as microalbumin, in the urine that we screen for. And then with that kind of inflammation and that protein leak, we think it's the protein that ultimately causes more inflammation and scar formation in the kidney that leads to a decrease in function over time. So what we usually are seeing in diabetic kidney disease are kind of three things. So that protein leak, high blood pressure or higher blood pressure, and a decrease in function. And a lot of you may kind of know about that decrease in function as a function of glomerular filtration rate, or GFR, on your lab reports. And so anything that, go ahead.
No, I was going to say, you explained that really well, because it is, all of you listening, it is complicated. But I think now's a really good time to say, because you mentioned the protein leak and the GFR, what kind of abnormalities on a chemistry panel, because we all get chemistry panels from our doctors, what kind of things would you look at? And I know that, and sometimes there's a little E in front of the GFR too.
The estimated GFR, correct. So the cool thing about the kidney is that your chemistry panel is 100% kind of figured out by the kidney. So it modulates every single one of those labs. It controls your sodium and your potassium, your bicarb, your chloride. Your kidney's involved in all of that stuff. But for you guys, in regards to looking for decreased clearance, the creatinine is one that you can look at. And so when we are not able to filter creatinine as well, sometimes that creatinine level will increase in the blood. And so you'll see this rise compared to your previous values. And then reciprocally, the eGFR is an estimated glomerular filtration rate, which is basically a formula. And different labs use different formulas, but this is a model that's been tested in chronic kidney disease patients. And that estimated GFR will give you kind of an idea. The way that I kind of refer to it is like, what percentage of kidney function do you have left? And that takes into consideration both kidneys working together for clearance.
Yeah, and I know that say a little bit about the different stages of diabetic kidney disease, because
So,
I'm stage 3.
yes, and that's
Why
great.
is that? I know that.
So in general, chronic kidney disease, whether it's diabetic kidney disease or another form of kidney disease, it all follows those same kind of general parameters with in regards to GFR ranges. So in chronic kidney disease stage 3 or CKD stage 3, that means that your GFR is between 30 and 60. So there are kind of actually different understanding of severity between 30 and 45 and 45 and 60. So there is kind of like a CKD stage 3A and a 3B, but overall, CKD stage 3 is between 30 and 60. CKD stage 2 is going to be between 60 and 90. And then kind of going the other way, stage 4 would be 15 to 30, and then 5 would be less than 15. When we talk about dialysis or need for dialysis, usually we're talking about a GFR less than 10, but we really want to see you guys before you get really advanced in regards to your chronic kidney disease.
Yeah, we're going to get to that. Okay, now I think this is a really important question. Some patients seem to get diabetic kidney disease earlier than others. Some never get it. Some get it at a young age. And I know some of the determinants we can't predict, but what are the main abnormalities that lead to diabetic kidney disease? Of course, glucose levels over the long haul.
Right.
I think we all know that. What else?
Right. And so that kind of hemoglobin A1C, that sweet spot is around 7%, right? So over 7%, you can start to have some of those more vascular complications, including the diabetic kidney disease. But in regards for type 1 diabetic and the time frame, I think that it's important to recognize that though diabetic kidney disease is one of the leading causes of needing dialysis and transplant in the United States, only 30 to 40% of diabetics ever get kidney disease. So there's a lot of genetics at play that we really don't have a good handle on, that there's a lot of research into about really how to better prepare patients or reassure patients kind of over time. So I think that most diabetics are terrified of their kidneys getting worse and want to do everything to try to prevent ever needing to deal with dialysis or transplant in their lifetime, which I think is a good thing. To take care of their health. But, like we said, it's okay to recognize that it's the rare chance that you'd be at risk even for diabetic kidney disease. So when we see a type 1 diabetic, and let's say they've had their type 1 diabetes for more than 25 years or less than 5 years, we actually think that it's probably not necessarily diabetic kidney disease, that those are kind of extremes that we should be looking for some other cause. But most type 1 diabetics, if they come to us and start to have that protein in the urine between like 10 and 20 years, we take it more seriously as most likely related to their diabetes.
Yeah, and what I've seen in myself and my patients that, and I'm sure you've noticed, the progression can be quite variable.
Yeah.
And there's a standard, but I, believe it or not, oh gosh, not long after medical school, I noticed protein in my urine, and then, my kidney function has been about the same, stage 3 for 10 years. Other people progress faster. So I would just say that it's so important to be screened, and your blood pressure and your blood glucose levels. Bethany, say something about the symptoms, because as I understand it, there's no real symptoms in the early stages. Maybe you can talk about that.
Yeah, so that's the reason why you're kind of listening to us today. The importance of actually following with a physician. It doesn't have to be a nephrologist, but a primary care doctor, an endocrinologist who will screen your urine and look for the microalbumin and check your chemistry and watch your creatinine trend. Early on, we would say every year, once a year is the recommendation. But if you do see a change, you're going to want to be a little bit more aggressive with monitoring that a bit more frequently and potentially getting that referral to the kidney doctor, because and that's with every type of chronic kidney disease, not just with diabetes. There really aren't symptoms until you're pretty advanced, and at that point there's very little that a kidney doctor is really going to be able to do for you to slow progression at that point, but they can obviously prepare you for that next step in life.
Yeah, and that's why we're having Dr. London talk about eye disease next, because a lot of it's blood glucose control, it's blood pressure control. There's no symptoms in the early stages, and the damage, the small vessels that get damaged, as I understand, they're the same size in the eyes as they are in the kidneys.
They are, you're right, and about 60% of patients, right? If you have diabetic retinopathy, that's one of the questions we ask. About there's a good chance that you likely also have kidney disease as well related to your diabetes.
And, that's just like you said, that's why screening is so important. Is there anything we could avoid to prevent damage to our kidneys?
Other than the glucose control and the good blood pressure control, right?
Anything not to do? Like I know
not to do. Okay.
Careful with certain dyes, like when you get a CAT scan.
Yeah, for sure. So, right. So let's say in regards to prevention, without actually being formally diagnosed with diabetic kidney disease, I can't say that you need to be avoiding anything really, to be honest, other than just really being healthy and taking good care of yourself and your diabetes. But patients who do have diabetic kidney disease, I think that it's important to know that some of the medications you may take or procedures you may undergo can put you at risk for having a change or an acute kidney injury that can then ultimately influence your function long term. So there is a phenomenon called contrast-induced nephropathy, which can happen with CT scan iodinated contrasts. It's not something that we worry too much about now because contrasts have changed tremendously, and it's usually a very temporary thing. However, your physician needs to know if you're going to be undergoing this procedure, because they may ask you to stop your ACE inhibitor or your ARB, your angiotensin receptor blocker, as well as metformin before some procedure like that, in the event that you may have a change in your kidney function, even temporarily, and you do not want to get into trouble and have a worsening kidney injury. So that is something to be aware of. Also, depending on kind of your kidney function, we may recommend minimizing medications like Motrin, Aleve, ibuprofen, naproxen, Advil. These are medications called NSAIDs, commonly referred to as NSAIDs. And they change the hemodynamics of the kidney artery. And so if you are on medications like lisinopril or losartan, some of these other blood pressure medicines that also change the hemodynamics, you may set yourself up for a risk of having an acute kidney injury. So it's always best to just talk openly with your physician about what medications you do take and any concerns that you might have, any procedures you're undergoing, so we can reevaluate kind of the safety of things.
Yeah, that's so important, especially the NSAIDs, like because they're everywhere, they're over the counter. Mm-hmm. And for the most part, if your kidneys are good, it's not a big deal to use them here and there, but there are a lot of other things we should be using. And I would just add to your comment, Bethany, that if you're going to get a test like a CT and they're going to use dye, just make sure your doctor knows. Mm-hmm. You know what I did at UCSD? I told them I was definitely allergic to dye. So I'm not really. So I just don't want to make sure that if I'm unconscious, they don't just give me a big dye load.
Yeah.
It's nice to know that there's better dyes these days. So when should someone with diabetes see a kidney doctor?
So to be honest, I think once they start leaking protein and they start to have that initial protein leak, I don't think it's a bad idea to have that first exposure and consult with a nephrologist. I just feel like, again, education is so important. The nephrologist likely will educate and look at all the medications you're on, talk about maybe some other medications that might be kind of in the pipeline or coming out that you may be a good candidate for, and then potentially send you back to your primary until your chronic kidney disease does advance in stages. And I would say, chronic kidney disease stage like 3B, or obviously around CKD stage 3 is a good time, because I feel like at that time we can try to slow progression. Once you're more advanced than that, it's a little bit harder. So I think that stage 3 is appropriate.
Yeah, I appreciate that. Same with the eye exam. Even if you don't go very frequently, you're going to check in, make sure you're doing everything you can. I want to remind everybody, before I give you the last word, Bethany, that in the health fair, in the TCOYD booth, you can download a free copy of the Taking Control of Your Diabetes book. We have a good chapter on saving the life of your diabetic kidney, is what it's called. So, Bethany, what closing suggestions, remarks you can make before we say goodbye?
Yeah, so I think I would just really be excited to talk a little bit about the SGLT2 inhibitors that are getting a lot of press these days. From a kidney standpoint, we've had very little to offer our diabetic kidney disease patients instead of diet, exercise, weight loss, blood pressure control, get on your ACE or your ARB. But these medications are really changing the course for a lot of our diabetic kidney disease patients. Harder to say for type 1 still. I think it's a little bit of an interesting conversation to have still. I don't know. Hopefully the evidence in the future, though, will be more positive in that direction to help you guys as well.
Yeah, Bethany, we did talk about the SGLT2s. We listed all of them, on the opening session. So,
Cool.
We all realize that where do they get these names up for these drugs? So, well, listen, thank you so much. Thanks for taking care of me, my patients, and taking the time to educate all the folks joining our conference today.
Of course. Yes, it was a pleasure. Good luck, everybody. Stay safe out there.
Okay.